Talking about cerebrovascular disorders. Thank you. So a couple of main things can happen, right? What's going to be one of the major things that can happen in the brain with the vascular system? We can have a bleed or a stroke. Okay. We could have a hemorrhage. We can also have a blockage, right? We can have something that's almost like a precursor called an aneurysm. Okay. Just like the abdominal aorta, where you get an expansional lesion, right, of a blood vessel. Okay. Now the problem with this is what? It can rupture. Okay. So depending on where it is, how big it is, you know, the brain is an iffy thing, isn't it? If they go in and try to resect that, it's different from even the aorta, they don't like doing, right? Unless it's really expansive. Okay. So it quite often is going to be in that circle of Willis. Bad news, right? Because if they go in and they screw up, there goes your main supply to your blood supply to your brain. Okay. So, but if they don't take care of it, it's very expansive, like in hemorrhage anyway. Now, the thing with people like this is you have to maintain systemic blood pressure, have to be careful with forcing of stools too, right? If they increase that intrathoracic pressure with Valsalva's maneuver, we all know what that is, right? With the Valsalva, just making sure. With Valsalva's maneuver, you know, bearing down with the closed glottis, you're going to increase your intrathoracic pressure. What that does is it puts pressure on the venous system, which will put back pressure up into the internal jugulars. Okay, you could see it, right? If you see somebody buried down really hard, you could see that expansion of those jugulars. So you want to keep systemic blood pressure maintained. You want to make sure they aren't straining at stools. At stools, with the proper straining when they are having a bowel movement. Okay, here's that circle of Willis, and we like in that circle of Willis, that's where we create these aneurysms. They're a different type. They're berry aneurysms that can present, the other one's escaping, fusiform, okay, aneurysms. They're different shapes. What I want you to understand in general is an aneurysm and what can happen if that continues to expand, okay? So here's a picture of that berry aneurysm, and it looks like a little berry on a stem. Okay, it looks like a little berry on a stem. Now you can see that's not very stable, is it? Right? You have that expansional lesion of that blood vessel, and it's just like a balloon. If I were to take a balloon and blow it up halfway, it would still be fairly strong. If I were to take a balloon and expand it to twice its normal size, or what it should be, of course, the walls are going to be very thin. Now the chances of it expanding are going to be more, probable. Now, aneurysms can happen in anyone. They're going to be more predominant in people with, high blood pressure and atherosclerosis, but this can be congenital. People can be born with this. And that's that scary, somebody dropped and they just died because they had an aneurysm they were born with. Excuse me. Okay, so CVA, or cerebrovascular accidents or stroke. Now, I think are they calling these brain attacks now? They were, then they weren't, then they were, I don't know, CVA. So, okay, so a stroke. So a couple things can happen. So that aneurysm can blow up and we can hemorrhage, okay? And then any of the brain tissue beyond that point is not going to get its proper nutrients and die, okay? We can throw a clot, okay? We can throw an embolism. That would be your occlusive cerebrovascular accident. Do we understand the mechanisms behind clot formation? Have you guys ever gone over that? Yes, no? Some yes? Okay, I'm seeing some yeses, some no's. So that means we go over it. If you really don't want me to talk more, say, yes, I know it. I don't need to talk about it. No, I'm just kidding. I want to know if you don't know stuff. So let's go over this, because this is actually pretty interesting. This is important stuff to know. So I'll throw in some clinical and applicable stuff with it. So let me bring my viewers at home in here. Okay, so think of blood vessels. Okay, let's start with just the blood vessels, and I take that long tube and I turn it on end, so we're looking at the inside of a blood vessel. Okay, so here's our blood vessel. We're actually going to talk about this in 2 weeks, but let's talk about the basics right now. On the inside of blood vessels, if we have a lot of sugars, if we have a lot of carbohydrates, or if we're genetically predisposed to this condition, we can have a lot of inflammation inside of our bloodstream, okay? Not a lot, higher levels of inflammation. that inflammation likes to erode the lining of the endothelium. Okay? Now the endothelium, guys, is just one cell thick. So if we erode that, then we're going to have exposure of that basement membrane. Okay? Then what that basement membrane likes to attract to itself is fats. Okay? You start to attract fats to it, and you start to get a buildup of fat on that inner lining. Okay? If that condition of inflammation, a high level of fats continues, well, so does this. And it can continue until it's all the way around or until it's thickened on one side. Now, this layer of fat also likes to attract clots, okay? Platelets and red blood cells. So we get this deposition of fat, and then we sort of get this area of turbulence that'll build up a clot. So the clot, ironically enough, I'm going to change colors. Didn't even think about this. Okay, it's not going to be blue, it's going to be red. But the clot will form attached to that fat on the lining of the blood vessel. Are you with me? So if that clot stays there, and the fat keeps building, and the clot keeps building, and the, blah, 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 what's going to happen? You're going to cut off blood supply, aren't you? Okay? So that is going to be a thrombus. So deposition, the increase in inflammation that we see inside the body will wear away the lining of the inside the blood vessels. We'll get a deposition of fatty substances. We'll get a deposition of a clot on top. If it gets big enough to block off the arterial supply, it's a thrombus, thrombotic condition. If the clot breaks off, though, we all know what that turns into, right? Whee! Takes off, turns into an embolus. Okay, and then that travels, and it travels until it can't go no more, and it finds a blood vessel that is smaller than it. Okay, we good with that? So if we're talking about what I have occlusive and then I have hemorrhagic. Hemorrhagic should be separate from occlusive. See what I'm saying? I sort of have the notes messed up a little bit there. I apologize. So occlusive would include TIA, which we'll talk about, thrombotic, and embolus, which they call occlusive in your book. Hemorrhagic would not be occlusive, right? Because hemorrhagic would be the blood vessel breaking open. Okay. Now, so we went over thrombotic, we went over embolus, okay? We went over hemorrhagic. Now, TIAs, though. Okay, what happens with a TIA is a clot gets lodged, and then it does what? Dislodges, and it keeps moving. Now, the good thing about that is hopefully it moves on to an area where it doesn't get lodged again, and there's no permanent damage, so it's going to be transient signs and symptoms, okay, for up to, I think, 24 hours. That's it. But the negative is that patient's prone to what? Growing clots for some reason, okay? Either they have that buildup of atherosclerosis, or some people tend to have thicker blood, okay? So TIA is going to be a transient ischemic attack where the clot lodges. They'll have signs and symptoms of a stroke, and then it dislodges and those signs and symptoms go away, okay? Now, TPA we know about, right? Tissue plasminogen activator, which is what they'll administer to break up that clot, okay? Any questions on that? That's all bread and butter stuff you guys are probably good with, right? Okay. So central nervous system infection. So we can get bacterial or viral infections, right? People who are immune compromised can get like fungal infections, okay? That's going to be people that are not able to fight off that infectious agent as well, okay? We could get an infection in the meninges, which obviously would be meningitis, an infection in the brain, which would be an encephalitis, okay? Myelitis would be infection of the spinal cord, okay? Meningioencephalitis would be meninges and adjacent brain. And this is, they have the immunizations for this because it is nasty stuff, right? Especially bacterial, nasty, nasty stuff. Now, an abscess will be a local infection. And what can happen is if you have an infection in a different area of the body, that infection can get into your bloodstream, just like the malignant embolus that we talked about, and it can end up in the brain and lodge itself into the brain. And that infection will embed itself into an area and cause an abscess. Okay. So acute bacterial meningitis is going to be the more aggressive form. Okay, people have to be hospitalized and put onto an IV antibiotic. Okay. Causes inflammation at subarachnoid space. Bad stuff. Chronic bacterial meningioencephalitis can be from diseases such as syphilis, okay, which we don't see, right? Because what is syphilis? What is syphilis? Why is it easily treated here? Syphilis is it is an STD. Is it a virus or bacteria? Bacteria. So we only see this like in third world countries where they don't have the treatment for it and they don't have the education. But the other thing about syphilis is what? It has really kind of funky signs and symptoms, right? Syphilis presents as like a flu, goes away. Then it presents as what? Do we don't? Okay, then it presents as a whole body rash. That goes away. But guess what the last sign and symptom is? It infects the brain and the spinal cord. Oh, we just had somebody say they see it in the inmate population. I didn't even think about that. Ooh, God bless you. So, okay. How interesting. So they actually get what are called gammas in the brain. Okay, and it destroys the brain. But anyway, it could turn into meningitis encephalitis. Lyme disease, can lead to encephalitis and tuberculosis as well. But once again, we don't see those because they're bacterial and we could take care of them. Viral meningitis is a little less acute and self-limiting. Okay. So meningeal signs. I've got a nice little video for this. Do you guys do these meningeal signs? I'm always curious about what Brzezinski's and Kernig's. Yes, no? Okay. So I see some yeses. So we're going to go through them again. I have a short video for this. Brzezinski's is when you bring the head up and they're going to flex their knees up, right? And I always kind of thought, I've heard different things about the responses. I've always thought it was because of the traction of the spinal cord, right? Because there's not a lot of room in there. You get inflammation. And I've always thought that bringing the head up is going to traction that spinal cord and cause them to, almost try to like take the pressure off. But then I also just heard something about being reflexive, that it sort of stimulates some reflexive reactions. So could be either or. So Brzezinski's and Kernig. Let me just zip this video up for you. Okay. Oh, my people at home? Oh, yep, you're zeroed in. Good.
An easy way to assess for Meningeal signs is the Brzezinski's and Kernig sign. First Kernig sign is the following. We're going to flex the hip and also flex the knee. And then we're going to extend the knee with a flexed hip. All right, Jason, I'm going to just bring your leg up, just relax. Flexing the hip, flexing the knee. All right? And now I'm going to extend his knee. And if you let me know if you have pain, and if he does, this would be considered a positive Kernig sign for meningeal irritation. All right. Any discomfort with that? No. All right. Excellent. That's Kernig's. Now, Brzezinski's is using the neck of the patient. You come to the head of the bed, and you just ask the patient to relax, and then I bring his neck forward. And with this, if I see any hip or knee flexion, that would be considered a positive Brzezinski's sign. All right, Jason, just relax. Noticing if there's any flexion, there is none. This is considered a negative Brzezinski's sign. Again, the Brzezinski's and Kernig's are for meningeal irritation.
Seem so young, don't they? Okay, so those would be the meningeal signs. Now, let's see what else we have to go. Okay. So Ray's syndrome, we talked about before, that post-viral condition, okay, affiliated with aspirin, we talked about that. And brain abscess. So that's going to be a localized area of infection that gets into the brain. Okay, once again, coming from a different location. I would think that there would be some sort of systemic immune compromise as well for this to happen. I don't think this is, because you get infections all the time, right, that your body's fighting off. So principally, this will happen in the white matter, Okay. It must be removed and antibiotics given. Seizures are a usual sequelae for this. Once they have that damage in that area, the astrocytes are actually kind of laid down almost like a scar tissue. Okay, and that scar tissue will not be functional, and the effects of that is they'll have seizures after this happens. Okay, it could lead to a collection of pus between the dura and the arachnoid. Oof, it just sounds so scary, doesn't it, to have those types of infections in the brain? Okay, so brain tumors we talked about in that first section, but I want to talk to you about pituitary. Okay, the pituitary, once again, is going to regulate what in our body? What? Hormones. Okay. Do you guys remember the two parts of the pituitary? Anterior and posterior. Okay. So we've got in the brain the hypothalamus, kind of this nondescript area of gray matter, the infundibulum, and then the pituitary. And the pituitary has two parts. So this is, imagine this is, I'm the worst drawer in the world. Although that is not bad. I should take a picture of that because I can't draw. Okay, so this is, Superman, whatever, because it looks like he's flying. And it would really be up here. But anyway, so we've got the front of the body. That's what I want you to see in the back of the body. So we've got anterior pituitary and posterior pituitary. Okay, so anterior pituitary is made up of glandular epithelium. So it's closely packed cells. Okay. Posterior pituitary is made up of nerves. So where we tend to get tumors is anterior, right? Because nerves don't what? Create tumors. Okay. So anterior pituitary tends to get the tumors, and we will have an over or under secretion of different hormones. I was just making sure I remembered this before I went over it with you. The mnemonic for the hormones that are released from the anterior pituitary is flat peg. Okay. And the reason I want to go over this, even though it's off book a little bit, is because if there's some sort of hormonal change in somebody that presents from all these different hormones, it could be a pituitary problem. And if you're, God, when you get into like endocrine problems, it's a nightmare, because it's controlled, hypothalamus talks to pituitary, which then goes through the blood, which gets to the target organ. There could be dysfunction at any one of those levels. So just to give you a little bit of a tip. So if there is a pituitary tumor, it would come from these anterior pituitary regions with the epithelium, okay? And it would affect one of these hormones, okay? So this is what's called follicle stimulating hormone. Okay. Eggs and sperm are known as follicles. Follicle stimulating hormone would create or mature eggs and sperm. Okay. Luteinizing, and I always spell this wrong, so let me know if this is wrong. I can memorize everything, I can't memorize this silly word. Luteinizing hormone is going to help to regulate testosterone, estrogen, and progesterone. Okay. ACTH, adrenocorticotropic hormone, is going to help to regulate those cortical hormones. Regulation of salt, potassium, glucose. Okay, ACTH, adrenocorticotropic hormone. Thyroid hormone. Going to regulate what? Metabolism. Prolactin regulates the production of milk in a female. Endorphins. Well, endorphins are used, endorphins are used for that like runner's high. Okay? If somebody's in extreme stress and their body kicks in with endorphins, but it's also used as a neurotransmitter. Okay? So you're not going to really see any systemic effects with that. Growth hormone. Okay, growth hormone. So if you have a patient who has difficulty, either they're too small or too big, there could be a problem with growth hormone, ACTH. You get Cushing's we talked about last week or the week before. Okay, prolactin, I mean, any one of these can become a problem, okay, if there's a pituitary tumor, okay? Most likely it's growth hormone and ACTH. For some reason, it likes to affect those two, okay? Does anybody remember, just for giggles, what the posterior pituitary release is? What creates the milk letdown reflex? Oxytocin. So the posterior pituitary hormones are going to be oxytocin, an anti-diuretic hormone, which prevents what? It's not a trick question. Anti-diuretic hormone is going to prevent urination. So if we're moving into a period where we feel our blood pressure is lowering or our solution concentration is becoming too concentrate, our body will release anti-diuretic hormone, which will reabsorb what? From the kidneys, in the kidneys. Salt and water. Okay, anti-diuretic hormone. Okay, so a little bit off book, but good little nuggets of knowledge. Okay. All right. So brain tumors. So see those 3 brain tumors that we talked about in the previous lecture and the pituitary tumor. Okay, so what condition is this? This should be easy because we only went over 1 or 2. And where is it? Well, that's hard to tell. It's an abscess for sure. What's happening there? Why does it look whitish around it? What's our body trying to do? It tries to encapsulate it. When it tries to encapsulate it, it'll encapsulate it with calcium. That's why it turns out whitish. The cells around it start to break down. One of the things that they'll do is they'll get an excess deposition of calcium into them as a response to it. You get a little walled off of a calcium area, calcified area, I should say. Okay, not fully calcified, but the area around it is. Good. Condition is this. And so this is the last time you have to do this today, Lulu. Lady Lulu. A lot of lights on and off today. I like a lot of pictures with CNS, so it sticks in my brain better. So where are we? A couple reasons I put this picture on. What is this, first of all?
Pituitary tumor?
It is. Very good. This is a pituitary tumor. I know that I've shown this to you before, okay? Because they can go through the nasal cavity. That's what's right in front of it to operate on it, okay? The pituitary is in what's called the sella turcica in the base of the brain. Sella turcica is part of the sphenoid bone. It looks just like a saddle. That's what the word means. Sella turcica means Turkish saddle. So the pituitary sits nice right in there, okay? So with a pituitary tumor, it's going to actually expand that sella turcica. So it's not going to be as small as it should be. It's going to expand it. And you can see that expansile lesion there. Why can't we see it so well? If I were to take myself and put myself into a CAT scan or an MRI right now, I prefer an MRI for this. Why would mine not be so obvious as this? You're on the right track. What have they done to this patient? Yeah, they've injected a contrast medium. And I don't know what would be used for this, but they've injected a contrast medium that's had uptake into that pituitary gland so you could see it better. So, okay. Same thing with MRAs, a magnetic resonance angiogram. They're going to put that contrast dye in there. All right. Gosh, should I make up some more stuff or should we leave early today? I think we should leave early today. A little bit. I kind of buzzed through stuff.